Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. And today I have a special guest in our show, my good friend, Sean Keys. Thank you, Sean, for joining us today. I'm just going to introduce you to the listeners. So Sean Keys is a pediatric orthopedist in our hospital, and you've been with us how long now, Sean?
This is starting my fifth year now.
Fifth year.
Fifth year, yeah. Completed
It's been
4
5
years,
years.
renewing that contract. Yeah, starting our fifth year together.
Wow. And correct me if I'm wrong, Sean, you came to us right after fellowship, is that right?
Straight out of fellowship from Cincinnati Children's. Yeah, this is my first big boy job.
Right. So you went to med school, no offense, many years ago in Lincoln Memorial University, is that right? Did I
Correct,
pronounce
yeah.
that right? That's an osteopathic degree in Tennessee. And then you went to do your orthopedic residency in Summa Western Reserve Hospital in Ohio, right? And after
Yeah,
that,
that's correct.
fellowship in Cincinnati Children's,
Yeah, that's correct, yep.
which is an amazing children's hospital. I know a lot about it because I did my fellowship in Pittsburgh, not too far away. So again, thank you very much for coming on the show. Let me just say to you guys that Sean Keys is probably the consultant I use the most because here in Florida, kids are out and about all the time. And I see a lot of kids with fractures. And thank God we have pediatric orthopedists to consult. So Sean Keys and I speak on the phone quite often. So again, thank you, Sean. Thanks for coming on the show. And I wanted to have this discussion because, again, this is something that I see in the pediatric emergency department all the time. And I feel lucky that we have you and your team. But as you probably know, many kids, most kids actually in the country, are managed in the community by general emergency physicians, not necessarily fellowship trained like me, who may or may not have an orthopedic specialist to consult. I think they rarely have a pediatric orthopedic specialist to consult. So the reality is that most kids who end up coming to the ER with fractures don't have people like you to kind of watch over them. And what do you think, or what have you seen as the biggest, I don't want to say mistakes, but pitfalls that made by ER doctors, whether it's pediatric trained like me or general emergency physicians who see children? What is your experience been?
Yeah, so first off, thank you for having me on the show. Really happy to be here. Finally got me nailed down. Took us a while to get these dates together, but
Well, you're a busy guy.
glad you were able to pull it together for us. Yeah, so there's a big difference in the management of fractures in children's between our adult orthopedic surgeon colleagues and the pediatric surgeries. So we spend an extra year of training just working on kids, specifically those kids who are still growing. And what we know about kids when they break their bones is as they grow, they have the ability to remodel and straighten their bones out. So they don't have to be perfect or perfectly straight. Now, we don't want kids running around town with some crooked arms, because that's bad PR and they can break again. But, as long as the skin on top is relatively neutral and doesn't look deformed, and if the bone's a little crooked underneath, they'll grow themselves straight, provided they have enough growth remaining. The biggest thing that even you've probably noticed now is we send a lot of people home. We don't think a lot of these kids need surgery because even though the bones are displaced or angulated, they'll do just fine with either a well-molded cast or a well-molded splint that we can put on in our office. And for the most part, we don't even use any anesthesia for these kids. We'll use what's called quote unquote it's okay anesthesia, where we throw on Disney Plus on our phone, we talk to them, we distract them, we use all the techniques that we learn being both parents and working with kids, that you can distract them and you can take a bent bone and just modeling and molding that cast, you can straighten it out. My job as a pediatric orthopedic surgeon largely is to talk people off the ledge, right? So their kid fell off the swing, they broke their arm and it's all kinds of mangled and crooked. They went to the ER out in somewhere, Ohio, Tennessee, now we're in Florida. And from the moment of their care, they knew their kid needed surgery. They knew they needed surgery. And they come into our office and we're like, look, your child's 4 years old. They're 20 degrees angulated. This is fine. It's going to be okay. You take off the splint and they look at the arm and it's really not that angulated. You put on a well-molded cast, you take an x-ray, show that it's less than 20 degrees. You follow them pretty closely in the beginning and show the parents, it didn't move. It's okay. And then you also walk the parents through it and tell them it's going to be fine. It's going to be okay. The reason we know that is because of kids in Hawaii, right? And so all the little islands around Hawaii, those kids get broken bones too. And the hospital's on the Big Island, and they can't get to the Big Island for a couple weeks based on ferries and boats and the ability to get there. So by the time they show up, they're 3-4 weeks out, and those bones are healed, right? Kids
Wow.
heal like salamanders, they're super fast. And so what they did was they designed a study because they had a treatment choice. They said, these kids, their arms are crooked, but they're healed. So do we take these kids? Do we cut the bones and reset them and fix them? Or do we watch them and watch them grow? And there's some pretty amazing natural history papers and pictures that you can look up and see these bones that are 30, 40 degrees dorsally angulated. The arm is all kinds of crooked, even when you look at the skin, and you look at it 3 or 4 months later and it's straight. It's straight. You can hardly tell they ever broke it. And that's just putting on a cast, not even doing anything, letting the body take care of itself. So that's the biggest thing that I notice in difference is we don't have to do surgery on a lot of these kids. We do spend a lot more time talking with the parents saying, you know what, it's okay. And it helps having years of experience and kind of logging those cases and showing them, hey, look at this arm. This kid had the exact same fracture you had, and it's worse. And he was even a little bit older. This is the x-ray 6 months later. Tell me where the break is. And you can't find it. It's normal. And so that's the biggest thing that I've noticed. Even people who come to us for a second opinion, they just want to hear it from a pediatric orthopedic surgeon. And now it's kind of heresy that a surgeon is talking you out of surgery, right? But
I
it's the
love
right
that.
thing to do. And that's what I tell people. I love to do surgery. I love it. It's what I do. It's what I went to school for. But the reality is I love to do surgery when it's indicated. And it's not always indicated in these kids.
I love that. That's great. I got to tell you. So, sounds to me, and again, I love that. I love hearing that. That you, like me, are a very big supporter of PEM rule number 4, which I teach the residents all the time. Less is more. I love that, and I got to tell you, I love it when the surgeon recommends against surgery because to me that sounds, very legit. Surgeons like you love to operate, but if the kid doesn't need it, that's great. But I got to tell you, and this has happened to us, when I spoken to you about certain kids, consulted you, even myself as a pediatric emergency specialist, we've seen dozens if not hundreds of kids with fractures. I still struggle with that. A lot of times kid comes in, I get an x-ray, and to me the bone looks pretty bad and pretty crooked, and it looks to me like the kid needs sedation and reduction right now. And I'd love to learn from you. Do you have, if you have, some kind of rough, easy to remember rule of who needs sedation and reduction, who needs to be what I call splint and sent?
So yeah, and so obviously open fractures, things with neurovascular compromise, those need reductions, right?
Right. So that's
The
easy because I always
That's
teach the
easy.
residents the sicker the easier. So if the kid is very
Yeah,
sick, that's easy. He needs you, not me.
that's the easy stuff, right? But what do you do with the kid who has the crooked arm that comes in after falling off a swing? And so the easiest thing I can tell you is 10, 15, 20 for the forearm and 10, 5 for the leg, tibia. And
Okay.
so starting off on the forearm, so 20 degrees, everybody under 10 years old, 20 degrees distal, 15 degrees mid shaft, 10 degrees proximal. And that's how much angulation you can accept for these forearms. Now, keep in mind that you're seeing these kids acutely.
Right.
You're seeing them when they just got hurt. So
Right.
when they come in, they're all kinds of banged up and crooked. But they have the natural ability, if we stay out of their way, to settle themselves. So what looks crooked to you right away, in 3 to 5 days will not look crooked anymore. The
Interesting.
soft tissues will adapt and it will accommodate. And provided the kid's not like skinny as a rail, they'll come in and see us 3 days later, and what you saw is not what we see. And so when you look at the skin of the forearm, it can mislead you to doing a lot more acutely than
Okay.
needs to be done. And so if you remember that rule for the forearm, 20, 15, 10 for kids under 10, and then you cut that by 5 for kids over 10, that's what you can accept. And so 20, 15, 10, distal, middle, proximal of the forearm.
For kids under
Um,
10.
for kids under 10. For kids over 10, 15, 10, 5 is
Gotcha.
a good rule of thumb. And now the reason that the proximal edge is not tolerant for as much angulation is because of pronation and supination. Your radius has that bow naturally to it. And when you start to lose that bow, you lose the ability to turn your palm to the ground. And that's where that becomes a problem. And so
I
proximal
understand.
fractures are less tolerant to angulation, which is why it's on the lower end. Now, the closer you are to the growth plate, the greater the remodeling. And so the adage is 20, 15, 10 for kids under 10. But I've seen kids who come to us 6 weeks after a both bone forearm fracture with 40 degrees angulation, and they're 6 years old. And they're 6 weeks out, and they just moved here from Boston, and they just saw someone 2 weeks ago, and they weren't that angulated. Well, things change over time, and we even watch some of those kids because it's the same decision tree. Do we take them, cut the bone, straighten them out, or do we let them remodel? Kids under 10 have an incredible ability. As long as their skin looks straight, you can let these kids remodel as long as they have enough potential. So in the beginning, if you remember that the forum 2015-10 for kids under 10, 15-10-5 for kids over 10, those kids you do nothing for. Put them in a splint and
Gotcha.
send them. Everything above that, it's a good idea to straighten them out. At least make the arm look straight. Even bayonet apposition up to a centimeter for kids under 10, and for kids over 10, 5 centimeters. Bayonet apposition, meaning the two bones are 100% displaced and laying on
Yep.
top of each other. As long as they're straight, that's fine. It doesn't need to be right on top. It's going to grow itself straight. It does just fine. I can show you some great natural history pictures of even patients we've taken care of where, yeah, again, we talk the patients off the ledge, be like, look at their arm. Their arm is straight. This cover up the fracture on the x-ray. You don't even see any angulation. This kid's going to do fine.
That's great.
Uh, for the tibia, so over 10 degrees, under 10, so 10 and 10. So under 10 is you accept 10, over 10, you accept 5. Anything above that, you should either sedate and reduce and cast, or call us and we take it to the operating room and we fix it. We either reduce and cast it, or we'll do some flexi nails or some plates based on that. So 10 under 10, 5 over 10 for tibias.
Gotcha. No, I think that's great information, easy to remember, and again, I think it really supports the less is more approach, which I love. I love those numbers because that will be easy to remember. Hopefully, our listeners can take notes and whatnot. But that's great. So really supporting the less is more approach. Like I said, I think that's great. And with regards to my physical exam and my history of kids with musculoskeletal injuries, this is something, again, I teach the residents and the medical students all the time. And I wanted to know if you agree with some of those PEM rules. Hopefully, you do agree because, I teach them all the time. I always tell the residents, the students, in a child with a musculoskeletal injury, if he's swollen, he's broken. Agree with that?
Agree.
Agree. If a child with a musculoskeletal injury has point tenderness, and oftentimes I tell them, hey, buddy, go like this with your finger, point with your finger, show me where it hurts. And when they show me a specific spot, if they have point tenderness, is broken. You agree with that?
Agree. Agree.
Agree. What about a child, with the exception of nursemaid's elbow, which I see often? A child had a musculoskeletal injury and then, for whatever reason, is not using the extremity to the same degree, also broken. Agree with that?
Agree.
Agree with that. Fantastic. And any of the above, with a normal x-ray, again, my approach is that there's a big growth plate there and there could be a fracture through the growth plate, aka Solder-Harris 1, still broken even if the x-ray is normal. In other words, normal x-ray doesn't really rule out fractures in kids with open growth plate, and I still place them in a splint, no big deal, and they can sue in a few days. Do you agree with that?
Agree. Yeah, absolutely. Put all those kids in a splint and we'll reassess them a week later, usually. And if they don't hurt anymore, then no harm, no foul. But usually 80% of the time they still hurt, they're still swollen, and we'll cast them.
Gotcha. That's great. I'm glad to hear that I'm teaching legitimate stuff and I didn't just make it up. Apparently the education I got was good. And one of the other things that I wanted to talk to you, and this is something that I guess in Pittsburgh it happened to me quite often because we were a trauma center. Now we're level 2 trauma center, so I don't see very significant traumas, but this is something that shows up in my ER every once in a while. And it's usually a crush injury of a finger on the ledge or the door, and the kid clearly has a fracture. They almost always do, but he's also bleeding. So this is, by definition, again from the learning I always got, an open fracture. And an open fracture in my book was always a surgical emergency. So I get an IV, I give NSAID, I give analgesia, and most of the time I learned that those kids really need to go to the OR for a washout because it's a very high risk for infection. But I think in the last 5 or 6 years since being as an attending, I've heard mixed opinions about that. So can you maybe clarify for us? You see a child with a fracture and some degree of bleeding. I'm not. We can quantify that. Do you agree diagnosis of open fracture? Do you agree IV NSAID? Do you agree admission, washout, all those?
So not for all of them, not anymore at least. And
Okay.
so yeah, that's definitely the traditional thinking. Anybody who has an open fracture has to go to the operating room, and we have to open that up and we have to debride it out. Starting with the poke hole injuries. So skipping over kind of the hand open traumas. So the forearm poke holes. What's important to note is, where did the poke hole happen? So were they on the tennis court, basketball court, or were they in the dirt? And so we want to differentiate those to a 1A or 1B. 1As are clean. So that happens on hard surfaces, basketball courts, cement. Those are clean injuries. Those, honestly, those go home. So those go home, and even the IV Ansef one-time dose, yes, totally agree with that. But even the
Okay.
literature of whether or not to continue antibiotics outside of the ER is arguable. There are some people who don't and have great literature to support it. There are some people who do 3 days, 5 days, 7 days, all pretty much do the same. And so, largely, if it's a poke hole and skipping over the fact that they even had a broken bone, as long as it's, or an open wound, as long as it's acceptable for broken bone standards to be splint and send, splint and send. My traditional rule is you give them some IV ancephaline ER. I like 5 days of just standard Keflex or
Hmm.
broad spectrum.
The PO version of NSAID, basically.
Exactly. I like
Yeah.
5 days of that, and then splint and send for a 1A, something that's on a hard surface, because there's some good orthopedic trauma literature to show that those don't really get infected. Now,
Okay.
it's important to note a 1B. So, a 1B is someone who has a lawn biopsy. That's the kid playing out in the pasture, playing out in the dirt, and they have a poke hole is where they got it. The challenge with those is, the bone comes out of the skin, goes out of the skin and hits cement or a rock. That's one thing. It's not picking anything up. If it goes out into the dirt or into cow manure or into the lawn, it's picking up dirt. It's picking up dirt and it's going right back in, almost like a core biopsy of the lawn. Those get infected, and there's some pretty nasty infections that come from the 1Bs. And so you'll never be wrong for admitting and debriding an open fracture, even a 1 in the operating room, for that reason. But 1As on a hard surface are fine to go home. We take care of a bunch of those from the outlying hospitals. But a 1B, a lawn biopsy, if it happened in the dirt, those are better taken care of in the OR. Take them in, bring the bones out, make sure there's no dirt inside the bone, and clean those out. Obviously, grade 2s and anything above, those go to the OR. And so timing to OR and timing to ANSAF, the literature is a little vague on that. What I was always taught and bred was within 6 hours, you want to take those and wash them out. Now, open hand injuries largely are treated in the ER. They don't have to go to the operating room. They do still need washed out, irrigated with just some simple saline. You don't have to add antibiotics. You don't have to add bacitracin. Their literature is pretty conclusive that that does not lessen infection if you put antibiotics into the solution that you irrigate with. But you can wash these out in the ER. There's some good hand literature from JHS, Journal of Hand Surgery, that supports even open tuft fractures. I agree. Those little kids smash their finger in a door, the nail beds avulsed and they're broken underneath and bleeding. Yeah, those are open. You take the nail plate off and you wash those out, and you can send those home. So open hand injuries largely are managed out of the ER, where you wash them out, you send them home, and if they need to be fixed, they can be fixed electively. Upper extremities, 1As can go home, be fixed electively if they need to. 1Bs and higher need to go to the operating room.
So that certainly helped, was because again, I think I see a lot of the nail bed injury, finger in the door. That's very common, and it's almost always broken. I think I have one patient in the history of being an attending when the finger got slammed in the door and there was no fracture. Then again, the kid was swollen, so probably a Salter-Harris one, if some
Right?
sorts.
Exactly.
But that's very good to know. So that means I'm going to bother you a lot less. I can just wash them out, do a digital block, wash them out, bandage them somehow, maybe buddy tape the finger or splint it
Yeah.
in some way and have them see you days later.
So yeah, and so again, I'm a big fan of the 5 days of Keflex after your IV antibiotic, and I usually see these within 3 to 5 days. We take off the
Fantastic.
bandages, we check it out, and sometimes we even take these to the operating room because, as you know, these little kids are difficult to take care of and hold still. And so, if they need a nail bed repair, sometimes we'll take the nail bed off in the operating room and just do it under a very controlled environment, wash it out again if it needs to.
Fantastic. All right. Well, this was, I think, for me, a very helpful discussion, Sir Sean. And again, I appreciate your time, appreciate your help taking care of our patients. I don't think I've seen so many kids with fractures before I got to Florida. It's really amazing because when I did residency in fellowship in the Northeast, during the winter, there were no kids with musculoskeletal injuries. And then the summer came, which is only like 2 or 3 months long. Then we saw fractures, and we didn't see fractures until the following year. But here in Florida, it's nonstop. So thank you very much for your time. Thank you for your help. Always appreciate it. And I hope we can do this in the future. Maybe we'll find a different topic for a different episode.
Oh, absolutely. I look forward to it. Thanks for having me on again.
Thank you very much, Sean. Thanks again for your time.
Have a good one.
And that's it for today, guys. Thank you very much for listening. Please check out pimrules.com for more information or submit any feedback if you have any. Would love to hear from you. Thanks again for listening. See you next time.